In this video, we're going to discuss pain. I'm going to start this video by asking a question that we all know the answer to, but might not be able to articulate. What is pain? Like stress, it's hard to define, but we know it when we see it. To fully understand what pain is, we need to understand three interrelated concepts: pain, suffering, and nociception. First, pain. Pain is a conscious perception. If you're not conscious, you're not going to feel pain. Consider something that typically causes pain. Say, running your shin into the edge of a coffee table. That's called a pain stimulus. As hard as this may be to fathom, a pain stimulus doesn't always lead to pain. A given pain stimulus, such as bumping your shin, may cause pain under some circumstances, but not in others. Pain can also occur in the absence of a pain stimulus. For example, there are lots of people with chronic debilitating back pain, but there's absolutely nothing wrong with their backs, at least nothing wrong that the doctors can find. And this isn't a freakish thing, it's actually very common. So pain is imperfectly predicted from the pain stimulus. It's also imperfectly inferred from a person's behavioral response. A person can say ouch or moan or groan even if they feel no pain. For example, basketball players, after colliding with another player, sometimes act as if they're in more pain than they really are so that they can draw a foul. On the flip side of that, people in pain often give no sign that they're in pain. It's very possible for a person to be in severe pain but show no signs of their pain in their outward behavior. Sports gives another great example of this. Many players try to act as if they're not in pain so that their coaches won't pull them from a big game. So if a doctor or nurse is judging whether or not you're in pain by watching how you behave, they're going to be wrong sometimes. The only real way to know whether someone's in pain is to simply ask them. Suffering is best thought of as an emotional response, and it's conscious too. Pain may lead to suffering if it's severe or sharp or long-lasting, but pain may not lead to suffering. Even though it doesn't lead to suffering every time, it's still real pain. And suffering can occur without any pain at all. Imagine emotional suffering. Maybe your partner just dumped you and you're sad and suffering, but that's not necessarily going to cause any physical pain. The third concept that you need to understand pain is nociception. In your other psych classes, you've probably learned that there are receptors in your brain for seeing, hearing, smelling, and tasting. Well, there are also receptors in both your central and peripheral nervous systems that respond to noxious stimuli, so stimuli that's harmful, hurtful, or injurious. These are called nociceptors. Nociceptors register mechanical, chemical, and thermal stimuli that have the potential to damage cells. Nociception, then, is the activation of one or many of these receptors. For all members of a species, the threshold for activating nociceptors is the same. So, for example, in humans, the temperature that activates nociceptors for heat is 108 degrees Fahrenheit. At lower temperatures, water just feels pleasantly warm, but at 108 degrees, the pain-detecting neurons activate and send an alarm. Nociceptors are attached to two different types of nerve fibers, A delta fibers and C fibers. A delta fibers are small myelinated fibers that transmit sharp pain. You might remember from past psych classes that myelination allows for faster transmission of messages. So they're basically nature's warning alarm. These fibers produce a fast, sharp, distinctly localized pain in response to mechanical or thermal pain. The information conveyed by the A delta fibers doesn't even need to reach your brain to have an effect on your muscles. When the signals reach the nociceptors in the spinal cord, they trigger an immediate muscular action that causes your body to move away from harm. It's like the reflex of pulling your hand away from a hot stove without actually feeling any pain, at least not consciously. C fibers are unmyelinated nerve fibers that activate after the alarm is sounded and the damage has already occurred. They produce a slow, persistent, diffuse pain that indicates continuing injury and forces you to tend to your wound after the danger is past. Normally, the activation of these receptors leads to pain, but not always. For some pain, there is no activation of these receptors, and this is probably the aspect of understanding pain that's the most difficult to accept. Nociception can occur without pain, and pain can occur without nociception. So to sum up these three concepts, consider this Venn diagram, these three highly overlapping circles, with the middle being the normal state of affairs. Note that you can have pain without suffering or nociception, suffering without pain or nociception, and nociception without pain or suffering. So for example, people with chronic back pain have pain and suffering without nociception. Another example is soldiers at war. They can have injuries, so nociception, but without pain or suffering, at least while they're still busy on the battlefield. There's one well-known theory of pain called gate control theory. Basically, the theory was the first theory to fully incorporate the psychological side of pain with the physiological. The theory basically says that when your body tissues are injured, such as getting a cut on your thumb, the nociceptors in the damaged area transmit impulses to the dorsal horn, which is part of your spinal cord. This is what I've circled in red here on this graph. Basically, this acts as a sort of gateway to the brain. This mechanism either opens the gate, which allows nerve impulses traveling through the A delta fibers or the C fibers to transmit pain sensations to the brain, causing you to feel pain, which is what the blue line is showing you. Or it shuts the gate, which prevents these impulses from transmitting pain sensations to the brain and keeps you from feeling pain. So what influences whether the gate opens or shuts? Part of what helps to open the gate is activity in the peripheral nervous system, meaning stimulation in the nerves in your arm or leg or whatever. That part makes a lot of sense. Of course, if you bump your shin pretty hard against a coffee table, that information has a strong chance of being transmitted through the gate to your brain. Basically, if the pain is intense enough, then the nerve impulses are sent all the way up to your brain, which gives you the pain sensation. And the more signals that reach your brain, the more pain you feel. These signals make it to the somatosensory cortex, which allows you to figure out where you're hurt. This is an image of the cortex. Basically, it's showing you that certain parts of your body have more sensation than others. The size of the area in the somatosensory cortex devoted to a particular region of the body determines how sensitive we are to pain experienced in that region. So, for example, the area corresponding to the fingers, which are particularly sensitive, are quite large. On the other hand, the area corresponding to the back, which isn't very sensitive, is quite small. But, and this is where the psychological influences of pain are brought in, the gate can also be influenced to open or shut based on neural activity from the brain. So your thoughts and emotions and expectations can play a role in either opening or closing the gate. For example, when you feel especially anxious or scared, your brain actually opens the gate and increases your potential to feel pain. In terms of shutting the gate down, if you're distracted or relaxed, your brain shuts the gate, effectively decreasing your potential to feel pain. Unfortunately, this whole gate mechanism isn't fully understood. So, this model suggests that pain isn't just physical and isn't just psychological, but these things are acting together in completely inseparable ways. So this model explains why there's often not a correspondence between nociception and pain. To illustrate the points I want to make about pain in this video, I thought I'd tell you some myths about pain and then explain why they're not true. It used to be thought that infants couldn't feel pain. It was thought that their nervous systems weren't sufficiently developed to actually feel pain. They also thought that giving an infant anesthesia would harm the infant, so they used to do surgeries on infants without anesthetic, or they would use only a very small amount of anesthetic during the surgery, but still not give the infant pain medications after the surgery was finished. And I'm not talking about the Stone Ages here. This was only about 30 years ago. And even now, infants are probably not given enough pain and medication when they have surgeries. Not treating infants for pain or not anesthetizing them during surgery can lead to poor surgical outcomes, not to mention a ton of suffering. Infants cry a lot, so when doctors see infants crying after surgeries, they don't take that to mean anything about the pain that the infants are experiencing. It's also sometimes thought that children can't feel pain, and in fact, it seems pretty obvious that they do. They just may not have the vocabulary to express it as articulately, and their pain behaviors are frequently thought of as exaggerated. Children also cry a lot, so, like infants, their crying isn't particularly informative, so doctors frequently write it off. Children are often not given any pain medications after surgeries as well. In one study, researchers found that mothers underestimated how much pain their children were in after a tonsillectomy. So mothers gave their children less pain medication than was ordered by the doctor. So assuming that the doctor is already prescribing less pain meds than he would for an adult, the child's getting quite a small dose of pain-relieving medications. Another myth is that treating pain with narcotics poses a serious risk of addiction. Narcotics are opioid painkillers such as morphine or codeine. So opiates are drugs containing opium or its derivatives. Opioids are natural substances produced by the body, like endorphins, that have similar effects to opium. Narcotics work by binding to opiate receptors, leading to an inhibition of the pain signal transmissions. These drugs are the most powerful treatment for pain, but have side effects, especially constipation, nausea, vomiting, and sedation, this fuzzy-headed, foggy feeling. Less commonly, these medications can also have respiratory effects, making it difficult for people to breathe, especially if they're taken in too high of a dose. This myth is probably the most serious misconception about pain, and it leads to a whole lot of unnecessary suffering. So I'm going to be perfectly clear here. People given narcotics for pain treatment in hospitals don't become addicted to pain meds. Drugs are used to manage pain, and then they're no longer used when they're not necessary. To fully appreciate this issue, we need to distinguish between tolerance and addiction. Tolerance is a normal physiological reaction to the use of certain drugs. In order to get the same response to a drug, sometimes more and more of it may be needed over time. With pain patients, tolerance rarely occurs. Small increases in dosage may be needed during the first few days of treatment, but once an optimal dose range is found, it can remain effective for months or even years. To measure tolerance, you need to measure the intensity of the withdrawal symptoms of a patient when you take the drug away. With pain patients, withdrawal symptoms are rarely seen. Even after months or years of being given narcotic pain medication regularly, pain patients can be given a series of decreasing doses for 3 or 4 days and then taken off the drug entirely with little or no effect. Data from hospitals illustrates this rather conclusively. In one large study of patients who were given narcotics for pain, only 4 of about 12,000 patients abused the narcotics, and in only one of those cases was the abuse considered major. In another study, they found that in over 10,000 patients from a burn unit, no patient became addicted to their pain medications. And these are patients who are taking high doses of our narcotics for weeks at a time. Finally, in studies of patients who are allowed to self-administer narcotics for pain in the hospital, patients tend not to use the highest permitted dose. They bring their pain down to a bearable level at which they don't have this fuzzy mental clouding feeling. They then continue to give themselves a dose to maintain this state. In the end, they don't use more than the medical staff would permit, and often they use less. Those are studies of patients in the hospital, but you see the same thing with long-term patients who are not in the hospital. One researcher conducted a meta-analysis looking at 24 studies on this. Within those 24 studies were a total of over 2,500 patients who were on pain medications for the long term. Only 3% of them became addicted, and if you ruled out patients who had abused other drugs prior to being on the pain medication, then only 0.19% became addicted. Addiction is characterized by drug craving, drug-seeking behavior, interference with physical health and psychological functioning, and relapses of using the drug after coming off it completely. Pain patients should never be confused with what our culture refers to as street addicts. Street addicts take narcotics to achieve psychological escape or release from fears, depression, and anxiety. Pain patients take narcotics to remove pain and dislike the psychological clouding and loss of affect that can come from these narcotics. Because there are people who choose narcotics as their drug of abuse, even though they may never have been a pain patient at all, and because our culture's negative attitudes towards street addicts have become generalized to people in pain who take narcotics, doctors and nurses find themselves in difficult situations sometimes, where they don't know whether a particular patient is a real pain patient or someone who has chosen narcotics as their drug of abuse and is just pretending to be in pain. One doctor stated that we live in a society that would rather prevent one addict from being formed than treat 100 suffering. The war on drugs hurts the war on pain. Because of this mindset, this equalizing pain patients with street addicts and this fear of patients becoming addicted, doctors usually prescribe low ranges of the drugs to patients in hospitals. Nurses tend to prescribe on the low end of that range, and patients try to take even less than the nurse offers. The result is that the patient suffers, and this suffering of patients is absolutely unnecessary. But doctors and nurses aren't well taught about pain. In medical schools, there are usually no classes on pain, and maybe only one or two mentions of it entirely. It's considered a nuisance factor, a side issue, not a main concern. A lot of people think that you should try to avoid taking painkillers and somehow save the painkiller for when your pain becomes super severe. Their thinking on this reflects this fear that if you start taking the pain medications too soon, your tolerance will increase to such an extent that there will come a time when nothing will help you. In fact, this isn't the case. Pain is something that's easier to prevent than to cure. What that means is that it's more difficult to control pain that has been allowed to build up, possibly because when pain builds up, other things tend to accompany it, like anxiety and stress. So you shouldn't wait until pain is out of control before trying to treat it. Instead, prevent it from getting out of control. Of all diseases, it's cancer pain that has been most inadequately treated. Over 90% of cancer pain can be treated successfully, but people worry too much about addiction. Even parents with kids who are dying of cancer are more concerned about opiate addiction than about treating their child's pain. under-medicating cancer patients results from both healthcare providers and from the patients themselves. Healthcare provider issues include the stuff we've already talked about: fear of patient addiction, concern about side effects, concern the patient will become tolerant of pain medications, etc. The issues on the patient side include a reluctance to report pain because they fear that it will distract the doctor from actually treating the disease, fear that pain means their disease is getting worse, and fear of being considered a bad patient. Patients may also be reluctant to take pain medications for the same reason as doctors don't like to provide them, because they fear addiction or being thought of as an addict. They worry about unmanageable side effects, and they worry that they'll become tolerant to pain medications. It's also commonly thought that pain is part of the normal aging process. No, this is not the case. Pain should be treated. It's not a normal part of aging to feel pain. Elderly people don't complain about everything. Their complaints should be taken seriously. In fact, elderly people also believe this myth, that pain's a normal part of aging. So elderly people are the group of people least likely to report their pain. People also think that pain has to have a physical cause to be real, but not all pain has a physical cause. Pain without an identified physical cause is just as real as pain with an identifiable physical cause. Pain that doesn't arise from physical injury is just as real as pain that does. 85% of people with back pain have no identifiable physical cause for this pain. And the same is true with 95% of people who have chronic headaches. Remember what we said at the beginning of this video? You can have pain without a pain stimulus and without nociceptor activity. In fact, all pain is a psychobiological phenomenon. You can't say that pain is solely psychological or solely physiological. All pain is a combination of psychological and physical factors. Unfortunately, there's a stigma associated with pain when doctors can't find the physical source of it. We call this psychological pain, and it's seen as the fault of the sufferer, under the conscious control of the sufferer, and a sign that the person just wants attention. People who have pain that doctors can't find a physical cause of have not been treated very well historically, and even today, they have to hunt for special pain management clinics. Another thing to remember is that just because we can't find the source of a pain doesn't mean that there's no physical source of the pain. In one of the articles you read for class, there was a story about a woman who had debilitating headaches for years, and the doctors couldn't figure out what the cause was. She finally went to a pain management clinic, where she learned that the headaches were caused by nerve damage that occurred during a surgery years earlier. People also tend to understand how we remember painful events. Consider these graphs of how much pain two different subjects felt during some painful medical procedure. The graphs show how intense the pain is and how long it was felt. There are three ways to think about this pain. You can think about the peak pain, which is the intensity of the pain at its worst. You can think about the end pain, which is the intensity of the pain at the very end of the procedure. Or you can think about the total pain experience, which is basically the sum total of the pain experienced. You can see from the graphs that patient A felt pain for under 10 minutes, with a peak intensity of about 8 out of 10, 10 being the worst pain you've ever felt. Patient B felt pain for about 25 minutes, with a peak intensity of about 8 as well. In fact, patient B's first 10 minutes of pain were identical to those of patient A. He just had some additional pain tacked on to the end. So which patient do you think will report feeling more pain? Observers usually think that patient B will report more pain because he had more total pain. However, when asked Patient A will tend to report more pain, and this happens routinely in cases like this. People think that the length of the pain is the most important thing, but if you study people who've experienced pain and how they rate their painful experiences, you find that what matters is not the total pain or the length of pain, but the peak pain and the end pain. Patients A and B have similar peak pain, but patient A has a more painful ending. Patient B's ending is less painful, so he reports less pain overall. So this study suggests that we can make patients think that they're experiencing less pain if instead of just ending a painful procedure at its most painful moment, we just tack on some extra pain at the end. As long as the extra pain is less intense than the peak pain, the person will report less overall pain. Doctors say it all the time. It's just pain, and it's not like it's going to harm you. This is even shown in how we describe chronic pain. Chronic pain can be divided into 3 categories. Chronic benign pain is pain that persists for 6 months or more and is relatively resistant to treatment. So chronic lower back pain would be an example of chronic benign pain. Recurrent acute pain is pain that involves a series of intermittent episodes of pain that are acute in character but chronic because the condition lasts for longer than 6 months. Migraines are an example of recurrent acute pain. And finally, chronic progressive pain is pain that lasts longer than 6 months and increases in severity over time. Examples of this kind of pain include cancer and arthritis. Most of the time, when talking about chronic pain, we're talking about chronic benign pain. However, chronic pain is never really benign. It can destroy your life and even lead to suicide. Most patients who request euthanasia request it because of chronic pain. For those who have never experienced chronic pain, it may be difficult to understand what life's like for people who do have to cope with chronic pain. Pain's subjective. We can't recreate our pain for someone else. Chronic pain patients point out that part of the curse of chronic pain is that it's very difficult to describe, and it sounds untrue to people who don't have pain. English just doesn't have any good words for describing pain. However, in a book by Melanie Thernstrom, the author does a good job of describing her chronic pain. She describes it like this. Pain was not like a violent intruder who batters his way in, wreaks havoc into parts. It was more like a sour domestic partner, intimate and ugly, a threatening, dirtying, distracting presence, yet one who refused to move out. I didn't like waking up feeling its grubby hands on me. I didn't like it interrupting my phone calls, especially when a friend was confiding a sorrow I cared to hear. I cared, but not the way I used to care, because part of me now cared only about pain. The author also provides a good analogy for describing the difference between acute pain and chronic pain. She says, to appreciate the difference between acute and chronic pain, consider the metaphor of a fire alarm. Acute pain is like a well-functioning alarm signaling danger. It ends when the fire does. Chronic pain is not protective. Its intensity bears no relation to the amount of tissue damage and may even arise without any apparent damage at all. It's like a broken alarm that rings continuously, signaling only its own brokenness. One recent explanation for how chronic pain gets worse over time without any new actual damage comes from brain imaging work with chronic pain patients compared to patients who don't have chronic pain. This work suggests that pain causes changes in the brain that diminish the parts of the brain that are used for modulating pain, which results in an increase in pain, which further atrophies the brain, which leads to more pain, and so on. In addition to hurting, pain can also harm you. First of all, it's a source of stress, and we all know what stress can do. Pain has also been shown to suppress immune function in rats and enhance tumor growth. In humans, there's some evidence that pain can cause immune suppression. This evidence comes from studies of surgery patients, which showed suppressed immunity after surgery, and that effective post-operative pain management is associated with less immunosuppression. So it's absolutely critical to keep patients out of pain following surgery, particularly if there's a risk of infection. We've already talked about how stress can cause immune suppression in previous videos. Now I want to suggest that in the long run, stress can also cause pain. Remember from the video about stress that in the short run, the acute response to stress is less pain, but in the long run, chronic stress may result in more pain. Patients who show up for surgery that are very stressed out therefore face a double whammy. First, stress has direct effects on immune function, as we discussed earlier. In addition, stress leads to more pain, and, as we just discussed, pain itself can lead to immune suppression. So stress has both direct and indirect effects on immune suppression. So what helps people cope with stressful medical procedures? Well, all kinds of psychological interventions help people cope with stressful surgical procedures, even very simple ones, such as an original classic study on this from 1964. In that study, the night before patients had surgery, the anesthesiologist visited them and then told them about typical physical sensations that they might feel after the surgery and taught them a simple relaxation technique that they could try after the surgery to reduce pain. The visits lasted only about 10 minutes. Patients who had those visits left the hospital on average 3 days earlier and required half as much morphine as patients who didn't have these visits. This is a huge effect from the psychological intervention. Since then, there have been more than 200 studies examining different interventions to help people undergoing surgery. Other simple psychological interventions have been things like giving patients procedural information, so what sorts of events would occur during the surgery and after the surgery, teaching people how to manage their emotions to stay calm during and after the procedures, such as emotion-focused techniques or relaxation techniques. And these studies have found all sorts of beneficial outcomes of these techniques, such as decreased anxiety and stress, reductions in hospital stays, fewer post-operative complications, better treatment compliance, less pain, and less use of pain meds. These treatments are easy to do and very short, some as short as 7 minutes, and very few lasting longer than 90. They're also inexpensive. Some even used a videotape or booklet, making them even lower cost, but still effective. In addition, some other studies suggest 2 things that might help surgical recovery that aren't even formal interventions, but are just small changes in the environment. One of them is distraction. One study looked at patients who had gallbladder surgery over the course of 9 years at one particular hospital. At this hospital, patients were randomly assigned to their rooms. The researchers found that patients in a hospital room that had a view had shorter hospital stays than patients in rooms with no views. They also needed less narcotic painkillers than patients in a room with no view. Another small change in the environment has to do with who else is in your hospital room. One study randomly assigned patients who were having a coronary bypass operation to have a roommate who was either preoperative or postoperative and was either there for coronary bypass surgery or there for some different kind of surgery. For these patients, those who had a roommate who had already had their surgery had significantly reduced stress levels before their operation and had shorter hospital stays, regardless of what kind of surgery their roommate was there to have. The researchers attributed this to social support plus anxiety reductions from having a positive model around. Okay, now moving on from surgical procedures, what about the everyday brief pain that we experience from time to time, like getting a shot or having dental work done? What helps people endure those kinds of things? Well, distraction helps with this kind of pain too. Lots of studies show that distraction helps people endure pain better than focusing on the pain, and that usually fits with people's intuitions. So there are two different mental strategies for limiting pain with distraction. One is to distract yourself by focusing on another activity. Albert Bandura did a lot of this research with kids. Remember him, Albert Bandura, from your intro psych class? He's the observational learning guy who beat up Bobo dolls in front of kids to see if they would follow his lead. Anyways, he also did work on distraction. He gave one example of a kid focusing on another activity to reduce dental pain. The kid, who was 11 years old, said, "When the dentist says open, I have to say the Pledge of Allegiance to the flag backwards 3 times before I'm even allowed to think about the drill." Once he got all finished before I did. The other distraction technique involves actually focusing directly on the pain-inducing event, but reinterpreting the experience. So another kid, this one 8 years old, said, "As soon as I get into the dentist's chair, I pretend he's the enemy and I'm a secret agent, and he's torturing me to get secrets. And if I make one sound, I'm telling him secret information. So now I never do. I'm going to be a secret agent when I grow up, so this is good practice." Some other recent work has looked at how social support helps people deal with pain. One group of researchers conducted a study in which people endured heat pain under 7 different conditions. While enduring this pain, participants could hold their partner's hand or the experimenter's hand, and in neither case could the participants see the person's face whose hand they were holding, so no communication was happening. Or they could hold a ball. Or they could endure this pain while looking at a picture of their partner, a picture of a stranger, or a picture of a ball. The control condition was simply looking at an X fixation point on a computer screen. All of these pictures were on a computer screen. This is what the study found. This graph is comparing each condition to the control condition, which is represented by the 0 line on the x-axis. So if the bar is below the x-axis, it hurts less than the control condition. And if the bar is above the x-axis, it hurt more than the control condition. And what you see here is that the partner interventions worked the best. So holding your partner's hand or looking at a picture of your partner were the most effective, especially looking at the picture of your partner. Photos of a stranger or a ball didn't do anything different from the control condition, and holding a stranger's hand or a ball hurt more than the control condition. One last thing researchers have found that helps people cope with pain, this time with a cold presser task, was repeatedly swearing during it. So they had people do this task, which is just keeping your arm in cold, just really cold water, while saying swear words, any word of your choice, over and over again, or in a different condition, a neutral word over and over again. And the researchers found that participants endured the pain longer and reported the experience as less painful in the condition in which participants swore. Finally, this isn't really a strategy for coping with pain, but it still relates to how much pain you feel. One researcher looked at whether it hurt more when people hurt you intentionally or when they hurt you accidentally. They had subjects receive shocks from a Confederate in another room who made choices online that the subjects could see. The Confederate could either choose to shock the person or to have the person do some other thing. In one condition, the Confederate intentionally chose to shock the subject. In the other condition, the Confederate clearly chose not to shock the subject, but the subject was told by the experimenter that the program was messed up and was therefore doing the other choice every time. So in both cases, the subject was getting shocked by the Confederate, but in one case it was intentional, and in the other case it was unintentional. Subjects reported the shock as more painful when it was intentional, the solid black line on the graph, than when it was unintentional, the dotted line. So that gray box is showing you the baseline trials. This is when the Confederate wasn't doing anything, and the experimenter was just showing the subjects what the shocks would feel like. As you can see, during the baseline trials, the two conditions didn't significantly differ from each other. However, once the Confederate started shocking people, the intentional shocks were reported as more painful than baseline, and the unintentional shocks were reported as less painful than baseline. Let's end this video with a battle of the sexes. Who can handle pain better, males or females? Well, of course we just all assume that females can handle more pain, given that women give birth. But studies more often show that men can handle more pain than women. There's one huge new study in which researchers looked at the medical records of several thousand hospital patients, all of whom were asked to rate the intensity of their pain on a 10-point scale. This question is routinely asked in hospitals and recorded in patients' charts. The researchers compared people with the same conditions. So they compared men with kidney stones to women with kidney stones, men with sinus infections to women with sinus infections, etc. And overall, women reported their pain as about 20% more painful than men with the same conditions. Lab studies have also shown this. In lab studies, men show higher pain tolerance than women. That is, they endure more pain than females do. In studies where people time how long subjects are willing to endure pain. But men may just be less willing to admit that they're in pain. When the experimenter or doctor is female, males don't admit to having as much pain as they do when the experimenter or doctor is male. So it's hard to interpret some of these gender and pain findings, since they seem to be filtered through our culture's expectations about how much pain people should have, and how we should express this pain. In one sort of disturbing study of patients in the hospital, female patients reported more pain than males, but the males were given more pain medications than females. This is because the females were frequently given anti-anxiety medications, like Valium, instead. I mention this study because what it shows is that doctors and nurses respond to complaints of pain differently if they're made by men than if they're made by women. This fits with a stereotype that women are whiny and men are tough. So if a woman complains of pain, she must just be anxious. Whereas a man complains about pain, it must really be pain. This is a stereotype that leads to a lot of suffering. In particular, if males can endure more pain than females, then they should receive fewer painkillers than women, not more.